conversation goes with it. Thank you for being here today. Many of you are surgeons and subspecialists, and this may not be a topic that feels pertinent to you. So also because you're all adult providers. But I hope that your takeaway may be just a little bit more of exploring further communication and collaboration with your patients and understanding what some of your younger patients are experiencing during their transition. If at any point you have trouble hearing me, I may lower my mask because you guys actually are well beyond 6 feet away from me. So let me just do that, unless David objects. All right, so that being said, what is my background? Why am I here today? Why is this an interest for me? I am a pediatric hospitalist. I do acute care. It has nothing to do with transitioning patients. And I love what I do. I love complex care. I love taking care of our complex pediatric patients. I love acuity of care. So this is really not the best platform for me to be practicing pediatric transition. Also do a lot of work with our medical students. I have 20 virtual visiting medical students that are rotating between July and November, so I do a lot with them as well. And I run our QI curriculum for our program. So you can see my academic interests have really steered away from this topic. This topic is still near and dear to me because back in residency, I trained at LSU in both internal medicine and pediatrics, and that particular specialty is great for this topic. So I became very interested in pediatric transition and trying to better collaborate with our adult and pediatric providers. So now that you guys are part of the LCMC Healthcare Network, congratulations, welcome to the family. We enjoy being part of your group now. I've done some work in the past to explore what that transition process is like and what it could be. Unfortunately, transition has definitely taken a back burner and lost some of its steam that it's gained in recent years because of new things like pandemics. But that being said, please try to take away at least one thing from this presentation that may help you, again, better understand where your patients are coming from. We're all trying to gain better perspective in today's world, and this is a topic you can all benefit from. All right, my objectives, helping you understand a new developmental stage of life called emerging adulthood. So we'll explore what that's like, again, to help you better understand the psychosocial barriers that may prevent your patients from transitioning and taking care of themselves, which you are asking them to do in the adult world. We'll define what is pediatric transition, not just from the medical standpoint, but again, the whole population. We'll select some at-risk patients that I want you guys to understand some of the outcomes they're facing because of poor transition, and also what some of the perspectives are from patients, families, and even adult providers that are seeing the brunt of poor transition practices. And then we'll take a look at Louisiana and the United States and what some of the transition efforts are like, funding, etc. All right, the gap years. A developmental stage that I knew nothing about until I started exploring this topic. There's a psychologist by the name of Jeffrey Arnett. He studied over 300 people, just young people in this age group, 18 to 29 years, over a 5-year period of time. And he said, you know what, this is a very distinct age group. So they're different. They're not like your 40 and 50-year-olds that have very well-established lives, hopefully at that point in time. And they're also not adolescents. They're much more independent, and we need to better understand what they're going through. So I'm going to show you a couple little videos here, mainly so I get a little mental pause and you do too to enjoy your lunch. It looks like our audio is going to be limited just to this computer, which is no problem at all. So we'll just defer the videos. It's just a little bit more, that's no problem. It's just a little more conversation about that developmental milestone. But we'll talk a little further on our own anyway. All right, so emerging adulthood. If you see a patient that comes into your practice, whether they're pre-op for a surgery, whether they're getting their eyes checked, whether they're having a baby for the first time, definitely recognize that if they're in this age group 18 to 30, they're in a distinct phase of life. And for you to better understand where they're coming from, try to understand their perspective. So there is kind of considered an early phase and a late phase based on this psychologist's work. And that makes a lot of sense. Why does that make sense? These emerging adults are exploring life for the first time. They're out of the house, potentially pursuing higher education, identifying who they are as people. They're often very unstable during this period of time because they're focusing on their self, they're making mistakes. So they're learning, they're growing, they're very optimistic. This age group is particularly optimistic and positive, so that can work towards your favor. So, but they are feeling very much in between, and so they may be coming to the doctor for the first time during this period of time where you're encountering them. So having those conversations in a more purposeful and meaningful may be very helpful for their outcomes for you for whatever type of practice you do. Adolescents and emerging adult populations. We study things all the time in the U.S. This particular study, the National Survey for Children with Special Healthcare Needs, which is what I'm particularly going to focus on for aspects of this talk. So they do this survey every 6 to 7 years. This data is from 2009 to 2010. It's been updated since, but for the purpose of the studies. Oh, sure. So for the purpose of this talk, the data trends are very similar. So I just left these numbers in here for you. Lots and lots of people that fall into this emerging adult population and this adolescent population. And you'll often hear me almost interchangeably or collaboratively use adolescents and emerging adults because pediatrics follows patients up into the end of adolescence, and then you guys take over. So we're going to collaborate, and we're going to kind of look at the trends for both of these age groups since they go well together. So for the adolescent age group 12 to 18, lots and lots of patients, millions of patients, almost 25 million. And of that 25 million that this national survey reported, those families, 1 in 5 had a child with a special healthcare need. So a chronic illness or a developmental disability. That's tremendous. So raise your hand if you've met a patient that's had a chronic illness or a developmental disability. All of us, right? Most of our patients that need health care maybe because they have a chronic illness or a disability, and how many of them potentially developed that during their childhood years, adolescent years, or emerging adulthood years. Many, many of them. So why this is pertinent to you. Just to let you know, most of these patients, these adolescents, most of them are going to survive into adulthood. So much so that 750,000 patients are being delivered into the adult health care network to you guys, into your hands every single year. So what is complex medical care? Again, these patients are just that much more at risk, whether they're adults, whether they're children. We know that their needs are above and beyond. From the pediatric standpoint, we are studying this so much more so. This particular study was called Status Complexicus. It was published, I believe, in Pediatrics of 2018, and they basically said over the last 35 years, the number of publications studying children with complex conditions has increased by over 400%. So we are definitely studying this because we recognize it's so important and it affects their outcomes, and those outcomes then affect you as their adult providers as well. So now we're going to transition, and I love using that throughout the talk as well, transition to talking about some of the at-risk populations. There's lots of populations to choose from that have special conditions that we need to address for the transition years because we're doing such a better job of taking care of them and helping them reach adulthood. Cystic fibrosis, for example, the life expectancy is over the age of 40 at this point in time. So I'm going to focus on these because I feel like they're very pertinent to adult providers. So, and we'll see how it goes from there. So for diabetes, there's 2 studies I'm going to highlight for you guys. Search for diabetes in youth. So this was a number of patients, I believe over 20,000 patients that they studied over a period of time. And they said, yes, 23,000 are diagnosed annually with type 1 or type 2 diabetes. So for your primary care providers, for ophthalmologists, for any of you guys that deal with complications from diabetes in your practice, we are handing a lot of patients over to you. The next study to highlight for you guys is from the Type 1 Diabetes Exchange Registry. They studied, I believe, over 19,000 patients over a period of time that were in that adolescent age group. Hence, they will become emerging adults. And they said only about a third of those patients actually achieved glycemic control, and this is what that looks like. All right, so here are your adolescent age group, emerging adults. And it's not until the age of 30 that they actually achieve improved control. So this is really important just to show you the healthcare outcomes, those measures that we can show that tell us that the transition age group, the adolescents and emerging adults, are very much at risk. Congenital heart disease, this one's super impressive as well. Children's is really focusing on our congenital heart disease program. If you haven't driven by Children's Our growth and expansion is tremendous. We have brand new towers everywhere. It's amazing, but this particular program has grown a lot, and we are doing a great job with them. So as a result, we have over 1 million adults living in the world with congenital heart disease today. So, and this is actually more so, I'll show you the next slide soon, this is more so, we have more adult patients than pediatric patients with congenital heart disease at this point. So one thing that's really sad, however, is that once we do a great job with them for their first years of life, most of them, in fact, 50% are lost to follow by the age of 13. Who knows what happens to them? And we know that in very severe cases, they show up in the adult side in an emergent way. And this just shows you the highlight of the fact that at today's age, majority of patients, 2/3 of them are adults that have congenital heart disease. Pediatric cancer. So this may, to me, I don't feel like I've encountered that many patients with pediatric cancer because I don't take care of oncologic patients. However, they are very much out there, and in the peds world, we're doing a great job. So over 80% of them are surviving. However, of those 80% or more that survive, over 60% have some type of late effect. Those late effects are numerous: secondary cancers, cardiovascular disease. Think about reproductive complications. Our pediatric providers really need to do a better job of preparing patients for their reproductive health, and then we can hand them over to you, and you guys can meet us there on the other side. And then not to mention psychosocial issues as well. We'll talk a little bit about mental health as a comorbidity that's very prevalent in this particular group. Sickle cell anemia. So we've talked about healthcare outcomes and how they're often extremely poor during this time of transition. What about some of the other aspects of the healthcare system? So I like to use the sickle cell anemia population to talk about system utilization. There's a couple studies I wanted to highlight, one of which is on this slide here. So from the Blood Journal, it's published by the American Society of Hematology. So they did a study of almost 20,000 patients over 2 years, and they said, what happens to these patients? Where are they going? They looked at 3 different arenas for that. They looked at ED visits, outpatient provider visits, and hospitalizations. And in that particular age group, our emerging adults, we saw this huge spike in ED visits. And look at that spike beginning in adolescence when many of them are lost to follow-up. And that really doesn't improve until later on. So pretty impressive. And then looked at readmission rates from another study in JAMA that was published shortly after this study. And they looked at, I believe, 19,000 patients as well, even 19 or 21,000 patients. And over a 30-day readmission, they looked at a number of patients, and for that age group, the same age group, 21 to 30, the readmission rate was 41%. Renal transplant, this is something that I thought was really cool. Most of my research for studying pilot populations for transition work have been with my renal or nephrology colleagues. So there's a UMC provider and a pediatric provider at Children's that I've partnered with to do some work. And Dr. Isa Shore showed me this slide. He said for this particular registry of renal dialysis patients, the incidence of graft failure peaks during the age of emerging adulthood. The reason why I put this arrow is because this is where we start to see the decline, and this is where our relationship needs to improve. Pediatrics and our adolescent patients, we need to prepare them, and then when we hand them over, we need you guys to help with that transition of care. A couple more at-risk groups to talk about, and then we'll transition to the next part of the talk. But mental health, you guys definitely know that this is a major, major comorbidity, and oftentimes these numbers tell us from the National Institute of Mental Health that a majority of patients with chronic illness and disability have a comorbidity of a mental health condition, and oftentimes that develops as early as age of 14. So in childhood, they're developing these issues. We actually just built a brand new behavioral health unit at Children's, which is standalone. It's beautiful. It was very much needed because this is such a prevalent thing. And this just shows the suicide rates, again, that really start to peak right at that age of transition. All right, and now to shift focus a little bit more, I wanted to think about what about the perspectives. So I don't have much in this talk on the patient family perspective, although it's something that I've studied as well. But for your benefit, for inflammatory bowel disease, I came across this particular study, and among the 384 providers that responded to the survey itself, about 30% or so response rate, they said, we asked them questions about, or this study asked questions about, did your patients know their medications? Not a lot of them did. As a provider, did you receive an accurate history from the pediatric providers? Only about 50% of patients, our providers actually received enough information to really take over care. And then about the same numbers, almost 50% felt confident to address the developmental aspects of their patient care needs. So this is a really big deal. It definitely lets us know that there's a gap and there's areas for improvement to help teach and educate you guys. Thank you to those who've been able to join us, and feel free to ask questions at the end or in between if you have questions about what we're talking about today, but it's on pediatric transition. So this would have been another video, and this was my only account from patient-family perspective of a patient with Crohn's disease who was diagnosed very, very early on in life, like under the age of 5. So pretty early for her, and how she just was in love with her pediatric multidisciplinary medical home. They were all pediatrics. They really loved her. They didn't want to let her go, but they knew that transition was a big deal. So they actually did transition her and prepare her to take care of herself, and she had a great success story. And I believe this is that, yeah, CHOP. So there are programs out there. There are a number of models out there for how to transition patients, and it can be a very successful, rewarding experience for both the patient, the families, and the providers. So now that we've looked at healthcare outcomes and at-risk populations, some of the perspectives of our adult providers, we've learned a little bit more about transition. Let's actually define it now. So, as defined by the Society for Adolescent Medicine, this is the formal definition that we still use today. Transition is a purposeful, planned process that addresses the medical, the psychosocial, the educational, and vocational needs of adolescents and young adults as they move from a child-centered to an adult-oriented healthcare system. I think all of this sounds extremely intuitive. This makes sense. So, but the part that we seem to fail the most at is not only in the medical arena, but also recognizing all of these other areas that these patients are transitioning. So that navigation process is very complex, but it's still something that we all are dutifully bound to contribute to for our patients. I want to highlight, again, just to help us better understand the difference, so between a child-centered care model to an adult-oriented model. So kind of what that looks like. Just imagine having a child. You may have children of your own. I have 2 beautiful daughters. So imagine that you are going to your child's doctor's appointment. They're a pediatrician who's known them for a long time. You are very much going to be very active in their disease management. Your children are going to heavily rely on you for their care coordination. But at what point does that start to transition to your child? When they're 12? When they're 18? When they're 26? Those are all things that we need to be thinking about. Providers are also really trained for very specialized conditions that adult providers oftentimes, it's not included in their training. And so these pediatric providers know what they're doing, and they're very much wanting to not let go of their patients. And then just based on some different kind of care models in and of themselves for time allocated to pediatric patients compared to the adult world, which we know is much more rigorous. So pediatricians often are able to spend a little bit more time, and there's that much more hand-holding that we just don't have the time to do in the adult world. So I've already alluded to many of the differences, but just to highlight them again, for an adult-oriented care model, patients are expected to be independent. We expect that from them, but how can we empower them to be independent? We have to help them reach that. We as pediatricians need to help them, but then their state of transition readiness may still be variable by the time they reach you. What are some other areas you can help them focus on? Hey, do you know what hospital to come and find me at if you need to get admitted for your Crohn's disease flare? Those are simple conversations you can have with them. Patients are also expected to be knowledgeable about their conditions. Maybe you have your nurse sit with your patient and say, you've just transitioned, this is your 2nd or 3rd visit with us. So let's go over your medications and see if you can learn what 1 or 2 of them do today. And then how do you refill a prescription? These are things they may not have learned how to do. Also as well, you guys may also encounter some patients that you've never taken care of before. So for example, we have a trach vent program, and that can be very daunting for an adult provider to take care of these patients. So we oftentimes have a very hard time finding a way to transition them to a primary care physician who just says, I'm so sorry, we just can't take them, we don't feel comfortable. So are there some tools that we can use to help with that process to bridge that gap? Maybe it's telemedicine and saying, hey, my trach patient is here, I think they may have a tracheitis, so can I get on the phone via telemedicine with the pulmonologist and just get a little bit of help? Transition barriers, we've already highlighted many of them, that hesitancy, but don't forget the other areas as well. Insurance navigation is a really, really big one. We'll talk a little bit more about it. And then transition readiness, we'll talk about that as well. This is a survey that I sent out in 2017 to our University Medical Center providers just right downtown. 75 providers, about 26% of them responded. So, and of those responded, this was kind of the biggest question that I asked among the survey questions. What is your strongest barrier to treating young adults with chronic pediatric medical conditions? The strongest barrier. We've learned about the barriers. What do you feel is the biggest one? Is it your knowledge of the condition, insurance limitations, health literacy, patient noncompliance? And I want to throw out this one. This is something that's in the literature. It's often cited. I don't think we should be comfortable with patient noncompliance as a term anymore. I think that when there's noncompliance, I think we should think of, well, what is the barrier to this patient? What is their perspective? What is holding them back or creating a health disparity that we need to recognize and try to break down with them? So we're, again, trying to broaden our perspectives in today's age across all borders. So, and this is one that I want to throw out. We already mentioned history. This one by far was the most common one, difficulty with care coordination. And I think this is the most common because it encompasses all of this. We have to coordinate all of this stuff for these patients, and it's a big deal and it's really hard, and we don't have the resources or the support services that we really need to do a great job. So where can we start? And the answer is one step at a time. Each time they come and see you, choose one area that you're going to focus on for the visit in addition to addressing their medical needs. And even if you're an ophthalmologist or a surgeon or whatever other type of specialty, all it takes is, hey, let's learn about one of your medications today, and you can contribute greatly to helping them feel more independent and empowered to take care of themselves. I'll give you a very quick moment on historical perspectives. I mentioned that transition is something that's up and coming, and it's hit some barriers. I think that this is not something